Well, welcome back. I'm going to turn it over to Jane Mahoney to introduce the panelists.
Welcome back. We are really pleased to have two case studies that we'll be presenting that will give a chance to sort of think about some of these aspects of use of EPIS for implementation. So Dr. Michelle Chui, who's a professor in the School of Pharmacy here at UW-Madison, will be presenting the first case study on her work of effectiveness and sustainment of a tailored over-the-counter medication safety intervention in community pharmacies. And then Dr. Melissa Datallo and Kris Krasnowski will be co-presenting on a case study, Essential Elements for Implementation and Sustainability from work they've done. Dr. Melissa Datallo is assistant professor in geriatrics in our School of Medicine and Public Health. And Kris Krasnowski is the Director of Communications and Community Relations at Wisconsin Institute for Healthy Aging. So I'd just like to remind you to please put all questions into the Q&A. And following our panel presentations, Greg and Lisa will provide commentary and lead our discussion regarding these case studies. So I'd like to turn it over to Michelle first. Thank you, Michelle.
Okay, Jane, can you see my slide deck?
I can.
I haven't quite figured out how to get rid of the the live captioning. So I apologize if that's just going to be there. I haven't quite figured out how to get rid of that, unless someone can quickly tell me how to remove the closed captioning.
Michelle, just go ahead.
Okay, great. I'm really a pleasure to be here today. I know I have a short period of time to zoom through the way I apply EPIS to my project. So the title of my presentation, Applying EPIS to a Systems Redesign Intervention to Improve Safety in Community Pharmacies. So just as a little bit of background for the project, I've been working in this area for over 10 years now. I am a pharmacist and health services researcher, and the focus of my work is in trying to improve medication safety, primarily for older adults who are community dwelling in the community. So people that are living in their own homes, and we want to keep them safe so that they can stay in their own homes and prevent emergency department admissions and admissions to the nursing home. So there's been a lot of work done in prescription medication, but really almost nothing done looking at over-the-counter medications. But older adults do rely heavily on OTC medications. Older adults represent 13% of the population, but they represent 30% of users of OTC. And unknown to many, older adults are at high risk of significant harm associated with OTC medication. There's good evidence that use of pain medication, cough, cold medication, and allergy medication and sleep medication represent medications that appear on the Beers list, and that they represent a significant number of emergency department visits actually of older adults. One of the problems, though, is that older adults are not familiar with the appropriate dosing of OTCs or how OTC medications interact with prescription medications. Many older adults feel that because it's OTC, that they are safe, and they don't need to have the precautions that prescription medication have. And importantly, providers, both prescribers and pharmacists, do not document or know what OTC medications their patients are taking. And so really older adults are kind of on their own related to selecting and using over-the-counter medications safely. So part of our initial work was developing a system redesign in a community pharmacy called the senior section. And it represented a lot of different components that I'm not going to go into, but we did do a significant departure, and we worked with Shopco Pharmacies to implement a redesign of the OTC aisles. And the results that we found in our initial study was that we did have significant reduction of OTC misuse. And importantly, this redesign fit with the pharmacist's workflow and did not add workload. So it improved safety while not increasing workload on the pharmacies. And the framework that I used is referred to as the SEEPS model. It was developed here at UW. And what I want to make note of in the SEEPS model is that inside the purple circle on the left-hand side is the inner context, or the internal environment in which we would think about the community pharmacy. And then you can see outside the purple circle is the external environment. So you can see how this human factors engineering model that I've used in a lot of my research fit very well actually with the EPIS framework. So in this model, you look at the components or the contextual factors inside the environment, and that of course leads to processes, which then leads to outcomes. Importantly though, one gap in our initial project was that we implemented this in 3 homogeneous community pharmacies within Shopco. So the patient population was white, generally upper middle class, and the pharmacies that we used was Shopco. And those of you might know Shopco, which has now closed, is imagine a Target or Walmart. It's a large mass merchandise chain. So moving forward on this new project, so what we did was we implemented in these 3 homogeneous pharmacies, and we wanted to be able to scale this up and look beyond identifying more variability within pharmacies and also variability in patient population. So enter this new project. We are partnering with Advocate Aurora Pharmacies, which is a large health system on the eastern side of Wisconsin. They have 63 community retail pharmacies within their health system. And the aims of the study are to adapt the senior section based on the characteristics of both pharmacies and patient population, to evaluate the effectiveness of the senior section, and then to evaluate the implementation of the finalized senior section. So this is a figure that we used in our grant application, and you can see how it mirrors the EPIS framework pretty nicely. All of the preliminary studies that we've done so far to demonstrate the signal of effectiveness that we found with the 3 pharmacies, we understand them to be in the preliminary studies exploratory phase, where we were really just exploring what is the intervention going to look like, how can we understand the needs of clinicians and patient stakeholders, and then what adaptations might we need to do. Then in the preparation phase, we wanted to understand the facilitators and barriers of implementation in this new setting, address additional adaptation, and then to develop the implementation plan. And then, so that's aim 1. Aim 2 is the implementation phase of really just implementing, monitoring, and then adjusting the implementation strategies to ultimately get to the sustainment phase, where we do want to facilitate the ongoing supports so that the intervention can continue to be delivered after the researchers step back and outside of the health system, and really turning it over to the health system to really manage this intervention on their own. Greg talked about the BCAN study, which we were very inspired by. So you can see some similarities here in this figure that we used to describe our study design with the one that Greg presented earlier today. And I just want to spend 1 or 2 minutes just talking about this. You can see that we use the EPIS framework very consistently with that study of looking at the exploration, preparation, implementation, and sustainment phases, and really using this framework to guide our understanding and the way we organized both the aims, the strategies we used, and also the outcomes that we used, ultimately to get at sustainment of this intervention. So in the exploration phase, we used a participatory design phase of engaging stakeholders. We conducted pharmacist and patient interviews, and then we used this information to develop the intervention that we did at Shopco. But we also did a survey of Advocate Aurora pharmacies to determine what their perceptions are of the intervention if we were to implement this intervention at Advocate Aurora. And the outcomes that we found were that indeed there was prevalence of OTC misuse. We recognized that there were barriers in place to selecting OTCs. And then we also determined that Advocate Aurora pharmacists did have an intention to adopt. So we had sort of fertile ground to work with as we went forward with the preparation phase. One of the things that really spoke to us about this framework is this cyclical rapid cycle adaptation perspective that EPIS had. And we really like that because we really came at this intervention as, this continuous, we're not going to get it right the first time. We might not even get it right the second or third time. And so we really wanted to incorporate this rapid cycle adaptation into the design of our study. So even though we did stakeholder meetings and participatory design in our exploratory phase, we also included it in the preparation phase as well. So we recruited stakeholders, patients, and pharmacist and technician pharmacy staff to engage in stakeholder meetings based on their feedback. We're currently in a process of pilot testing our current adapted intervention in 4 pharmacies with Advocate Aurora. And the goal after the pilot phase is again to engage in this adaptation process. What did we do well in the pilot? What can we do better in the pilot? And it's not only about the short-term effectiveness of this intervention from the pilot phase to the randomized controlled trial, but how can we also be thinking about the implementation strategy? What are we doing well? How are we understanding what is an appropriate way to implement this and getting feedback as well about the implementation strategy? That's going to lead us to a post-test randomized controlled trial where we are going to use 10 test site pharmacies and 10 control site pharmacies. They will be matched on pharmacy and patient characteristics. And then again, we will go about, even after the RCT, we'll go about doing some additional pharmacy staff interviews. Again, the goal is to look at short-term effectiveness of the intervention, really understand how to implement this strategy for Advocate Aurora. And again, really thinking about how can we help Advocate Aurora implement this in the sustainment phase. So we are not implementing, but that Advocate Aurora, but how can we help Advocate Aurora do this? And we can step back. At the end of the implementation phase, our goal is to then help Advocate Aurora implement this intervention in all 63 Advocate Aurora sites. I'm going to stop there. You can see that there's a phase of sustainment here, but because the idea about this short course is about sustainment, I expanded that to the next slide. So in the sustainment, our goal is to hand off the intervention from researchers to the health system to roll it out to 63 pharmacies. And we were challenged by this because honestly, it's a little scary to hand off something that we've grown and loved and really massaged and supported for years now and hand it off to a health system and lose control. So our guiding premise is that we want to be able to create the supports so that when we hand it off, Advocate Aurora feels very confident and comfortable actually implementing this. In terms of the data collection, though, our premises were that we really wanted data collection to be pragmatic and innocuous. We don't want to go in there again. We really want to be behind the scenes. So the outcomes that we identified were fidelity of delivery. Remember, this is a physical redesign of a system, and we know that that physical redesign can be morphed over time. We know that in pharmacies, they move things around, they may take signage up and down, things might get lost. And so the Advocate Aurora staff that we're working with, partners, they are going to actually go into these pharmacies and take pictures for us. And that's how we are going to determine whether or not there's fidelity of delivery to our system redesign. We're also looking at long-term effectiveness. We're going to use a secondary data source of OTC sales data. Do sort of unsafe OTCs continue to be sold less? And can safe OTCs be sold higher? So we're going to do an interrupted time series analysis to look at to what extent those sales change over time. And then we're going to do, so if you recall in our randomized control trial, we have 10 control group pharmacies that we collected data in during the randomized control trial. And then what we'll do is we'll do, when those control group pharmacies get swept into the 63 pharmacies with the implementation, we're going to collect some post data there to determine a comparison between misuse data and was the intervention successful, comparing the control group data that was collected in the RCT with the post data that's collected in the sustainment phase. And lastly, we're going to do a brief pragmatic study or survey 6 months after intervention to get staff perceptions of sustainability of the project. So that's pretty much my quick description of the study. I just want to quickly acknowledge my amazing team and then the funding sources as well for this project. And I am looking forward to hearing the questions at the end. Thank you very much.
Thanks, Michelle. That was fantastic. And I'm looking forward to hearing the questions and discussions too. So as a reminder, for the participants in the short course, any questions you have, put in the Q&A. And now I'd like to turn it over to Melissa and Kris for their case study presentation.
Hi, everybody. Can you see the slides okay?
We're
seeing your presenter view, Melissa.
Oh,
Click on display settings a little bit to the left there, and then, yep, click on that, and then swap present. There we go.
okay. Is it showing up well right now?
perfect.
Okay, thank you so much. It's an honor to be here today. Krasnowski and I are really thrilled to be able to share with you a case study that fits with many of the concepts of the EPIS framework, even though the study wasn't originally designed using that framework. I think it illustrates the key factors and how applicable that this is to practice. So my name is Melissa Datallo. I'm a geriatric medicine physician. Kris Krasnowski is the Director of Communications and Community Relations at the Wisconsin Institute for Healthy Aging. And we worked together on an implementation science study from 2012 to 2015 called Bringing Healthy Aging to Scale. And we'll summarize that study today and also explain how the results have been applied in the community over the past 6 years to support readiness of the Public Health Aging Network to deliver evidence-based health promotion programs to older adults in Wisconsin. So the study that we worked on was called Bringing Healthy Aging to Scale. And it was conducted at a time when federal policies were changing such that federal funding from the Older Americans Act was designated for evidence-based health promotion programs. Unfortunately, at the time, the dissemination of programs with a very strong evidence base to rural communities in Wisconsin was limited, despite training and support that the Wisconsin Institute for Healthy Aging had provided in delivering those. So there was a need to identify strategies that would both facilitate implementation of the evidence-based health promotion programs and also ongoing sustainability. So the objective of the Bringing Healthy Aging to Scale study was to evaluate an intervention that consisted of a quality improvement coaching intervention called NIATEX to see if it would increase the delivery of two specific workshops. One was Stepping On, which is an evidence-based falls prevention program. The other was called Living Well with Chronic Illness, which is a chronic disease self-management program. And so this diagram outlines the goal of the study, which is to help rural county aging units ultimately produce as many evidence-based workshops as they could support. There were 16 rural county aging units who were selected for the study. Again, they already had trained workshop leaders, but there were other barriers that they were experiencing to delivering the workshops, as they were selected for the study because they had not actually implemented any workshops at baseline. And the 16 counties were randomized to receive quality improvement coaching in this method called NIATEX, or no intervention on a waitlist control. So 8 counties received the quality improvement intervention, 8 counties were on a waitlist control. And Kris, who will be speaking about her experience in a few minutes, was one of the quality improvement coaches. Each site also identified a change leader at their site who was participating in the quality improvement intervention, and each site also identified an executive sponsor from the staff of their county aging unit. So I think I wanted to provide a diagram here just to illustrate the different groups involved in delivering the workshops and the different groups involved in the study intervention, because this is important context when we talk later about themes of barriers and facilitators that each county experienced when we're reaching their goal of workshop delivery. So, oops. This overlaps with many of the concepts of EPIS in terms of the county aging unit being the inner context, the community partners and often the workshop leaders being part of the outer context. And then you can consider the quality improvement coaching and intervention potentially a bridging factor. So qualitative research using interviews or studying other sources of data can be helpful to understand variability in quantitative outcomes, particularly if an intervention is complex. So we actually used mixed methods, qualitative and quantitative, to use multiple sources of data, including interviews, reports, and surveys, to understand the experiences of the site leaders and quality improvement coaches, and to understand from their perspectives, barriers and facilitators to workshop delivery, and understanding that variability in success. So there were 8 intervention sites over 3 years. At baseline, no sites had all of the resources they needed for implementation. Part of what they needed to do to deliver the studies was to secure the needed resources. And by analyzing the experience over the course of this study of the site leaders and the quality improvement coaches, we were able to take a qualitative approach, a conventional content analysis, to identify common features of counties that were able to be more successful and have higher workshop delivery. So these were the themes that came out of the qualitative analysis. First of all, the thing that all of the 8 intervention sites had in common was that none of the sites had adequate resources to implement the target workshops at baseline. And the site leaders in all of the counties needed to seek additional resources to implement their workshops. All of the change leaders had experience working in resource limited settings and used a variety of diverse strategies to overcome obstacles to workshop delivery. And while they all acquired those resources in different ways, those who were able to attain adequate levels of these 6 essential elements were able to deliver the greatest number of workshops. And so these were the 6 essential elements that emerged from this cross-case comparison. The first one was the quality and the strength of their external partnerships. In addition to their resources in their county aging unit, they often needed to develop partnerships in order to achieve the space, the materials, volunteer workshop leaders, connections with potential participants through external partnerships. The second was an ongoing source of workshop leaders. Both of these interventions required special training for the workshop leaders, and there were volunteers in many situations, in some situations, workshop leaders were on staff at the county aging unit, so there were different strategies there. But either way, if there was turnover, there was an important component there of being able to continue that service and to continue training. The third was agency leadership commitment. And this was part of the internal context of the aging units. The fourth was health promotion coordination tasks assigned to specific staff. So some of the sites had a specific health promotion coordinator, other sites didn't. But as long as those tasks were specifically assigned to someone on the aging unit, that tended to be a successful strategy. Organizational stability was really important. One site had a change leader leave during the course of the study and was not able to deliver any workshops. And then finally, the change team engagement was a factor that was really critical for problem solving and overcoming some of the barriers that were faced. This table is a high-level illustration of the 8 counties. So each county has a designated letter here, A through H. And on the left, they're the counties that delivered the most workshops, 6 over the course of the study. And on the right, the least workshops. There was one county that didn't deliver any workshops during the course of the study. And this rates kind of their self-reported and their interviews and reports levels of adequacy of these 6 essential resources. So as you can see, the counties here that had the most workshop delivery described the strongest partnerships, the strongest commitment from their agency leadership, renewable sources of their workshop leader training. They had very clear designation of roles with the healthcare promotion coordinator tasks, more stability in their county aging units, and greater engagement from their change teams. So I'm going to put this figure up back just as a reminder of the different people involved, the inner context of the county aging unit, the external context of the community partners and workshop leaders, and then the bridging context of the quality improvement coach and change leaders. As a reminder about who was involved, and then I'll turn it over to Kris, who is one of our quality improvement coaches, to talk about her experience helping sites address these barriers and facilitators, and how these findings from this study continue to be applied in community settings today.
Great, thanks, Melissa. So yes, I was one of 3 coaches on the BHAS project, and so I want to provide a little bit of insight into the development of these 6 essential elements. First, a key component for success is this organizational stability. So for many, staff turnover was a major challenge. 5 of the 8 counties in the intervention group lost 1 or more staff members during the study period. One county held multiple workshops in the intervention year, but the next year project staff were reassigned to other activities, and they had held fewer workshops in years 2 and 3. Losing agency directors was also a major setback, or folks who were essential to the taking on of the project. One county lost its director during year 1, as Melissa mentioned, and didn't deliver any workshops during the entire study period. So having a source of support from decision makers was critical. Another county had a committed change leader, but lost 2 directors and wasn't able to deliver any workshops in years 2 or 3. The one county that increased its staff size increased workshop delivery by year 3. So clearly having this organizational stability was a factor. Next, the commitment of agency leadership was also a huge factor in the success of the initiative. Agency directors who dedicated the time to existing staff or hired new staff were most successful. If the change leader was not the agency director herself, she needed to have direct access to the director or another key decision maker. In one county, the change leader was also the agency director, and she assigned 3 staff members to the change team during the intervention year, and then secured funding to hire a part-time prevention coordinator in the post-intervention year, and was able to increase the number of workshops offered that way. Counties where the agency director role was either vacant or filled by interim staff, or where the agency director was just not engaged with the change leader, those places were not able to sustain workshops in the post-intervention year. So again, it's clear there needs to be support from the top. Developing external partnerships also made a difference. And as Melissa mentioned, those counties that engaged multiple external partners held more workshops than counties that didn't, and the number of external partners mattered. One county employed sort of outsourcing strategy. So they used their funding to subcontract workshop coordination and delivery activity to a local community center that already had a developed infrastructure for delivering exercise programs and other programs to older adults in that community. So while that worked really well initially, it didn't yield additional workshops in the second post-intervention year, in part because they weren't able to sustain, and they had embedded that in one location only. So there was really, there was no potential long-term sustainability beyond the intervention. Counties that had multiple external partners mobilized broader community engagement, were more successful in both the short and the long term. Engaged, enthusiastic change teams were critical. The change team was a venue to kind of mobilize resources and execute plans. It's where the NIATEX process was taking place. Generally, the more people on the change team representing a variety of different organizations, the greater their chances of success. The change teams in the two counties delivering the most workshops over the study period included external members like community volunteers, representatives from partnering organizations, other interested people. In my experience as a coach, teams that met regularly with a fair amount of frequency and maintained a high level of enthusiasm for the project also fared much better than those that didn't. And it was very easy and clear, easy to see when a change team had lost some of its steam, maybe started out with some enthusiasm, but kind of lost some of its steam over the course of the project. I'd also add that using the NIATEX process improvement framework gave the kind of structure, and I also think some confidence to the change teams that they might have needed to move the project forward. Having some structure and following a process where they might have in the past just kind of winged it a little bit and not necessarily followed through, given having a structure, I think that made a huge difference in some cases and probably is continuing in some areas. Securing an ongoing source of workshop leaders was key to sustainability. Relying on agency employees alone, and Melissa mentioned this, agency employees alone to lead workshops was a temporary fix, but it wasn't sustainable long-term. Counties that were unable to recruit volunteers or that relied solely on employees to lead workshops weren't able to hold any workshops beyond the intervention year. So it was a real eye-opener in a sense that this is a capacity issue, and finding volunteers was the long-term, the only sustainable solution. On the other hand, counties, again, that recruited a substantial number of volunteer leaders, and that happened in 4 counties. They were the only ones still delivering workshops in year 3. So as there is turnover among workshop volunteer leaders, that happens pretty regularly, it's important to have an ongoing source of volunteers to replenish the base. And finally, health promotion coordination tasks need to be assigned to a specific staff person, and Melissa mentioned that as well. Volunteers are great for that, but it's important to have the key components of coordination, coordinating the volunteer workshop leaders and the workshop logistics, and organizations that didn't have a staff member or didn't have a partner, an external partner that embedded that within their organization, weren't able to continue to deliver interventions workshops past the intervention year. So fast forward, how have we operationalized these essential elements at WEHA? First, we recognize the need to adapt our organizational structure. So WEHA has grown significantly since the study period. We've expanded our network to include healthcare providers, other community-based organizations who are now offering our programs. So we no longer work exclusively with aging offices in the counties, although they remain a major partner for us. So we restructured to create a new status we call the registered program provider. And these are organizations now that embed WEHA programs into their agency work to ensure that even after a program leader is no longer active, that program or that provider organization maintains its connection to WEHA and gets support to sustain the program. We also adopted the essential elements into our new program provider readiness and sustainability coaching. So we added a position at WEHA called the Director of Program Provider Partnerships. That's a lot of P's, who serves as both a recruiter, but also a coach and guide for provider organizations to ensure readiness and sustainability there. My colleague in that position or one of our other program leads meets with potential providers to assess readiness based on the essential elements. Then she works with and coaches them to enhance that readiness. And we always encourage the creation of a local implementation team, which is a riff on the change team concept from NIATEX, to expand reach and capacity. And then lastly, we hold regional trainings with program providers and leaders to reinforce the essential elements. These trainings center on sustainability. We share strategies for making the case for program funding, developing partnerships for program recruitment and delivery, and then recruiting and retaining program leaders. That way we continue to kind of reinforce those things that we know work to provide programs in communities around the state. And with that, I'll stop and see if there are questions.
Thank you, Kris and Melissa. That was fantastic. I'd like to, so if we bring on our panelists now, I'd like to first see if our panelists have any comments or questions that they would like to direct to Michelle or Melissa and Kris.
You go first. Go, Lisa.
Thanks so much, you guys. This was such great time to be able to listen to both of these different projects. I learned a lot, even though I'd already read them, to be able to hear them and hear you guys speak about them. That was really, really helpful. So I have different sets of questions. I'm trying to map on to some of the questions that we're seeing in the chat. And then one of the things, Michelle, you had mentioned and made a really nice point in your figure of noting the importance of both the inner and the outer context settings when you were looking at your particular project. So you said that you knew that you wanted to be able to that it was going to be cyclical in nature and that you were going to be considering those two things. And one of the things that you said was, you said, we knew we weren't going to get it right the first time. And so when you think about your project and you think about getting it right, how much do you think about having to get something right versus maybe documenting but still continuing down the path before you know that you want to go ahead and revisit those cycles in both the internal and external contexts?
Great question, Lisa. Thank you so much. So there's a lot of tension around that because, you just want to move on the project and you want to get it right the first time and you want it to be effective and you want it to do, like, you want to have like, ooh, P is less than 0.05 and you have like statistical significance, and all of those things are pushing on you as sort of a, traditional health services researcher. But pharmacies are dynamic, people are unpredictable. You can't really predict how they're cognitively going to engage with the intervention. And so right now we're in this pilot phase where we have to decide, we've made our initial set of adaptation from the Shopco project to now the Aurora project. And now we're embarking on the pilot phase, and we had to decide, okay, when are we going to stop and just implement and know that, we'd like to tweak this a little bit more. We think it's not quite there, but then you have to just go, you have to move forward. And so we've really struggled in our team about, we're not at the effectiveness phase yet. We're not at the RCT. We're still at the pilot phase. We can still adapt. So actually that gives us a lot of comfort, I guess, that we still have time to improve on this. We still have time to get stakeholder engaged feedback. We still have time to do this better than what I think we have. And I think that when I look back on our very first, when we first engaged in the project to develop the intervention at Shopko, you know, I'm a community pharmacist. I'm a health services researcher. I've worked with pharmacies my whole career, and I actually thought I knew what I was doing. And what I found is that I didn't know anything. And so I think that was just very humbling for me, and has really led to a lot of growth in the way I think about how to develop interventions and feel like there's no real end to this intervention development phase.
Great, thank you. And I'm sure you do know some things, but I appreciate what you're saying. Greg?
Yeah, so I'm going to shout out to Michelle again, like really nice program of research here. Really enjoyed hearing about it and reading about it. So as you were talking and talking about implementation strategies and the approaches, I'm thinking, so, you know, who and what actually drives the marketing and display decisions in kind of large pharmacy organizations? Is that centralized office? Is how much latitude is there at the individual pharmacies? And really, how could strategies be designed to capitalize on variability in kind of those factors?
So Greg, you're just going to get me on a rant now. So I'm going to try and keep it short. In most retail pharmacy organizations, over-the-counter medications are marketed for profitability. It's a purely profit-generated endeavor for most pharmacies. And that would include for-profit national retail pharmacies, the chains that I'm not going to say, but you know what I'm talking about, as well as nonprofit pharmacies like Advocate Aurora. I think that the goal at the end of the day is to push product and maintain sort of financial sustainability. The problem here is that there's not really any implicit or explicit attempt to address safety in OTCs. And I think that that's just a major gap that I'm realizing. And I think that the safety issue actually continues to be a research gap as well, that people older adults don't understand it. I've had long conversations with Jane about this. I see Jane nodding her head. It's a major patient safety gap. And I agree with you, Greg, that most of these decisions are done by individuals who are not healthcare professionals, not patient-centered individuals. These are all just individuals working with manufacturers of OTC products and trying to jockey for position on OTC aisles to do this. And so it doesn't take into consideration things like older adults who are reading labels through bifocal lenses and having to kneel down and find a product. And they, have a very difficult time with their physical limitations. So I think there's so many aspects of this that we need to do better on. I don't think I answered your question. I just kind of went on a rant. So Greg, hopefully I clarified that.
No, I think the discussion is helpful in thinking about, strategies and I think, things like marketing. And I mean, we've seen that with the recent Facebook testimony, and that, sometimes there's people doing that. Sometimes it's AI platforms that inform those decisions. And I think, it's an opportunity maybe for implementation strategies, but it also has to do with the values, as you kind of mentioned with the nonprofit pharmacy, maybe the values are a little different. And so it's really interesting to think about that outer inner context dynamic in the process. So yeah, I really, yeah, I'm with you on the rant. So, well, yeah, I think that was my main question.
Yeah, so sort of continuing to build off of this idea of cost and resource. So what I hear you saying, Michelle, is there's this tension, right? There's this tension between the resources that in this case, big companies have, and then the resources that we have as scientists that are trying to come in and promote some change. And obviously we don't have those same resources. And so as we are up against that, that makes me think about Melissa and Kris's project. And in particular, Melissa, you had mentioned that at baseline, all 16 of the counties, none of them were prepared resource-wise for the implementation. And when I saw that, well, first of all, it just really struck me. I think that that's probably true more often than not, but we don't typically take the opportunity or the time to assess that and to figure that out at baseline. So I was wondering for you guys and for your project, how much of this is a factor of a research project versus what you would do in the real world? I know this project was some time ago. So now as this has been just, becoming part of the routine bit of practice, how do you still maintain that assessment of resource use and what's available to them? And then how do you kind of adjust your strategies based off of what you find?
I think that's a really great question. I think that was very humbling for me to realize too during this study about the resourcefulness of everybody involved. And since Kris was one of the QI coaches and continues to support sites in assessing their readiness, I'm going to let her take this question and talk about their readiness assessments.
Yeah, well, with back at that point, counties had some resources through the Older Americans Act. They were not mandated to do these programs. And so I think a lot of times, and over the course of my work in this area, it really does come down to priority. And sometimes priorities are delivered to you. You have certain requirements of programming that you're required to do. And then there are these programs that are critical and important for the community, but they're not necessarily adequately funded. And so they don't necessarily get the attention that they deserve. So to me, so much of the success when it came to counties being able to increase their numbers of workshops and numbers of participants that are taking part in evidence-based programming, it really came down to having a champion there who determined that this was something that was so majorly needed in that community that they were going to find a way to do it. So yeah, I do think, as Melissa said, it really does come down to resourcefulness and having somebody who has a real passion and recognition for how critical these programs can be to the health and well-being of the older adults in their communities that they serve. I don't know if that quite answers your question, but that's sort of been a running theme as we've gone to deliver programs. Organizations that for whom this is a high priority tend to really devote the resources and develop the capacity to be able to continue them and sustain them.
That's great. Just a slight follow-up question to that then, Kris. So then am I hearing that this is a formal part of your readiness assessment process, that you guys do some sort of a resource landscape or an assessment of some sort, just standard as part of your implementation process?
It is, although it's not a barrier. Like organizations who indicate an interest in working with us on any one of our many programs now, we've grown from having just a couple of programs to having over 10 different programs that we offer now. So there's readiness can also be dependent on the program that the organization is looking to implement. So we do, Jill, I know, who is our program provider partnerships director, along with Shannon and Aaron, who also are working in that area with different programs, do work as we onboard new program providers, do work with them to understand and help assess their readiness and help better prepare them to be ready. So they have a really good understanding of what it is they're taking on, what the expectations are for, as a WEHA program provider. We created a whole sort of document that helps walk them through what readiness looks like, to not to discourage them, but to encourage them, because we do also kind of coach them through how do you create partners, how do you create an implementation team, how do you develop additional capacity within your organization and outside of the organization to make these programs live in the community.
Fabulous, thank you.
One of the things I wanted to highlight which I think really is important in both of these case examples. And you had mentioned this, Greg, in your discussion of EPIS, is the role of policy as part of the outer context. And policy makes a huge difference in sort of overcoming lack of readiness, I would say, or lack of willingness, when there is a sort of a requirement or a policy driver.
I echo that, Jane. That's absolutely been the case for us, and it's partially also some of the impetus behind extending our provider network beyond the aging network in Wisconsin. So again, not to say we don't work closely with aging offices and aging and disability resource centers, we absolutely do. But it kind of extends beyond them now. We have healthcare providers, we have public health agencies who are providers, we have fitness centers that are providers. So we've grown our provider network a great deal, in part because we recognize the capacity issues of aging offices and the volume of different programs that they're required to implement. And while funded to do this work, it's not a requirement of being an aging office in Wisconsin. So it is something we certainly work with them and try to create collaborations to make it happen in those communities. But it's also one of the reasons we've extended our provider network to different organizations.
Yeah, so both Kris and Melissa, that's really interesting project. As I was listening and thinking about it, sometimes wasn't clear exactly what was outer context and inner context. And I think this is not that unusual, because we have to think about, so if you're operating in a state, is county inner context and state outer context? Or if you're operating in a specific health system, is the aging office outer context and these organizations inner context? And so I was struggling with that a little bit as I was listening to you. What are your thoughts about that identification of outer inner context for your work, and how things, as like Jane mentioned, policies feed into that, funding streams feed into that, and how do you position organizations and entities as you're trying to do the work of improving the health of older adults?
Mm-hmm. Well, that's a huge question. I don't know that we have necessarily framed it in those terms. I don't know that we think about it. I think we come to it in those terms because we do recognize these sort of external pressures. What is the environment that we're functioning in? And that can be different. There's certainly multiple layers of environment that we have to pay attention to. So, and then at the county level too, what is their reality and environment that they're trying to operate in? So those are those external sort of forces at work. And then I would sort of characterize the change teams, and that might include people from organizations outside of the original aging unit that we worked with. But that to me feels like the internal, where the internal context comes from. Again, I think having not used EPIS, but using the NIATEX model, I think we had a little bit different structure in terms of how we moved through the process improvement project. But again, I definitely see the pressures and the realities of both the challenges from the internal context and from the external side as well. That may not have answered your question.
Yeah, I can tell you how the change leaders and the reports and the interviews kind of talked about internal or external factors, and would love to hear your thoughts on how that fits with the EPIS framework better. But the way that this was discussed in the interviews was that, we work in an aging unit, and that looked different in the different counties, and we have internal staff. And so the change leader was one of the internal staff members. They may or may not have had a health promotions coordinator, and they may or may they all started with a director. And so sometimes the director and the change leader were the same person, sometimes they were two different people, but those were kind of the key people that were described as part of their internal context, at least in the interviews. And then they had some funding. So they had some funding for health promotion programming. And if they wanted to get additional resources, that was often talked about in the context of external factors. Either they had to apply for a new grant, apply for new funding, or they needed to find a partner that could offer, something they needed, if it was space, if it was volunteers, if it was marketing for their program. And so that was kind of the way that the people in the interviews talked about, here's our internal resources. If we need things, we can look to external resources. But I would love to hear your thoughts on which parts of those fit into which parts of the EPIS framework.
Yeah, I think as you're describing it, it really feels like, really working in a low resource setting. What we often see in low middle income countries, and cobbling together the resources. But the thing I did hear was the agency leadership commitment as being critical, even in the face of turnover of the regular workforce and volunteers. And we found something similar in a large scale study of sustainment of a practice across multiple service systems, that proactive planning, problem solving, commitment to the project at the higher level, where there was the ability to direct resources, or at least staff, towards working towards that goal, was important in the sustainment. So I think, to me, that could be, if that could be leadership. If it's at an organization, then it's inner context. If it's at a system, then I would consider it outer context. So if it's an agency within a county, how much does the county also support that? And that made me think, Michelle, in your description about, talking about both where you assessed intentions to adopt, and also the degree to which, Aurora was really committed. My question was, how does leadership commitment really show itself at the different pharmacies? And is it like Aurora, big Aurora, or is it each pharmacy in Aurora?
Yeah, so really good question, Greg. I was fortunate in my partnership with Aurora, because my pharmacist champion at Shopco that I collaborated with on the Shopco project moved over to Aurora and had a desire to continue the work that we had been working on together. So I just got really lucky related to that. And he's a great guy, and he had spent, quite a bit of time building trust with his pharmacists. One of the things that, though, is very interesting in thinking again about the pharmacist and the inner context, is that when we did the Shopco project, we were able to use, sort of, because we were only using 3 pharmacists, we were able to use the pharmacist exemplars. So we really were able to use pharmacists who had an intention to adopt, understand the value of it, were willing to spend time helping us with this project. In this project with Aurora, one of the areas of variabilities is the level of intention to adopt. 63 pharmacies is a lot of pharmacies, and just like any teacher, doctor, anything, right? Everyone has different gradations of being willing to adopt, level of buy-in, level of slack in their work life to be able to, do something extra beyond their current work. And so that's one of the areas in which we're really looking at to see how much that impacts the success of the intervention.
We're going to need to wrap up now. This has been just really great. I want to thank Melissa, Kris, and Michelle. And then Greg and Lisa for your comments and the chance to get to think about EPIS in action. So we are now going to move to a break, and our break will go until, how long will our break go?
Our break is going to be for 15 minutes. And during that time, we're going to switch over to the meeting link, which is being put into chat right now, so that we can participate in interactive breakout sessions. So again, 15-minute break, but you're welcome to join that link in a minute. We'll be right over there just to make sure your technology works. And we'll be doing some really interesting activities in small groups.
Great.